Welcome to our video on cervical neoplasia. Let's begin. In this lecture, we will go over the definition, pathophysiology, risk factors, clinical features, diagnosis, management, and complications of cervical neoplasia. Let's begin with the definition. Cervical neoplasia is characterized by neoplastic proliferation of cervical epithelial cells. The primary cause of cervical neoplasia is high-risk strains of human papillomavirus such as HPV-16 or HPV-18. These viruses spread via direct skin-to-skin contact, invade cervical epithelial cells, and induce oncogenic changes, thereby setting the cells on a path to neoplastic growth. This path usually begins with cervical intraepithelial neoplasia, or CIN for short. CIN is characterized by premalignant cellular changes in the cervical epithelium that may progress to cervical cancer. Here's a figure of the cervical epithelium that depicts the progression from normal cervical epithelium on the left to full-blown invasive cervical carcinoma on the right. As mentioned on the previous slide, this progression begins with cervical intraepithelial neoplasia, which is classified into CIN1, CIN2, and CIN3 based on the extent of epithelial involvement. CIN1 is characterized by mild dysplastic changes that are confined entirely to the lower third of the epithelium. CIN2 is characterized by moderate dysplastic changes that involve the lower two-thirds of the epithelium. And CIN3 is characterized by extensive dysplastic changes that involve more than two-thirds of the epithelium. Once these premalignant changes spread to affect the entire thickness of the cervical epithelium without penetrating through the basement membrane, the patient would be considered to have carcinoma in situ, which is a phenomenon that still technically falls under the category of CIN3. Of course, the moment the basement membrane is penetrated, the patient would be considered to have an invasive cervical carcinoma. Generally speaking, the greater the extent of cervical intraepithelial neoplasia, the more likely it is to persist and progress to invasive cancer. It is important to know that cervical cancer usually originates at the so-called cervical transformation zone, which is essentially an area of transition between squamous epithelium of the exocervix and columnar epithelium of the endocervix. Here's a histologic image obtained from the transformation zone of the cervix. Note the abrupt change from squamous epithelium on the left to columnar epithelium on the right, with the transformation zone in the middle. And here's an image of a healthy cervix. Note the subtle change in color from the smooth pink squamous epithelium to the glandular, darkened red epithelium that marks the cervical transition zone. It is at this location where the majority of cervical cancers arise. The risk factors for cervical cancer include high-risk sexual behaviors, for example, having multiple sexual partners, early onset of intercourse, immunosuppression, for example, due to AIDS, low socioeconomic status, cigarette smoking, and a family history of cervical cancer. Both high-risk sexual behaviors and early onset of intercourse increase a woman's risk of contracting a high-risk strain of HPV, and immunosuppression makes it more difficult for the body to subdue and eliminate the virus without intervention. Low socioeconomic status increases patients' risk for cervical cancer because these patients usually don't have access to adequate screening and treatment. Cigarette smoking suppresses the immune system and contributes to cellular oncogenesis. Lastly, a positive family history may confer a genetic predisposition to cervical cancer. When it comes to the clinical features of cervical neoplasia, early disease, for example, the CIN stage, is completely asymptomatic. This means that without adequate screening, the disease will continue to progress steadily towards cancer unbeknownst to the patient or her clinician until the patient begins manifesting symptoms of late disease. In late disease, patients may present with postcoital bleeding, pelvic pain, vaginal discharge, urinary symptoms such as dysuria, and or rectal symptoms such as dyschezia. Importantly, postcoital bleeding is the most common presenting symptom of cervical cancer, which is why it should definitely raise suspicion for cervical cancer if encountered on exams. The diagnosis of cervical neoplasia and cancer is arguably the most important and high-yield part of this lecture for the purpose of USMLE Step 2. The diagnosis usually begins with one of the following screening options: a pap smear, HPV testing, or co-testing, which means that a clinician performs both a pap smear and HPV testing at the same time. Following positive screening, clinicians may obtain a definitive diagnosis using colposcopy, with cervical biopsy, which is often accompanied by endocervical curettage to help sample the cells from the endocervical canal. Let's utilize this figure to highlight the general steps of a pap smear. First, the clinician places a speculum into the vagina to help visualize the cervix. Second, the clinician uses a soft brush and a spatula to gently scrape the cervix around its transformation zone to collect samples of the cervical epithelial cells. Third, clinician transfers the cervical epithelial cells from the tips of the brush and the spatula into a vial, which is then sent off for examination under a microscope and potentially HPV testing. Here's a histological image of cervical epithelial cells collected as part of a pap smear and placed under a microscope. The clump of cells on the left resembles a normal cervical epithelium. Compare this clump of cells to the cells on the right, which appear to be darker and have enlarged nuclei. These morphologic changes occur secondary to infection with the human papillomavirus, and when cells take on this characteristic appearance, they are known as koilocytes. Hence, presence of koilocytes on a pap smear suggests an infection with the human papillomavirus and warrants further investigation. In addition to knowing about the available screening modalities for cervical neoplasia, it is also important to know when screening is indicated and when it is not indicated. Let's utilize this table to cover the key cervical cancer screening recommendations in the general population, assuming the screening results are negative each time. For patients younger than 21 years old, no screening is indicated unless the patient is HIV positive. More on that on the next slide. Patients that are 21 to 29 years old should be offered a screening pap smear every 3 years. Once patients reach the age of 30, clinicians may offer several equally viable options. Those include a pap smear every 3 years, primary HPV testing every 5 years, or a pap smear with HPV co-testing every 5 years. Again, any one of these 3 options would be appropriate for this patient group. Once patients reach the age of 65, the general recommendation is to stop screening for cervical cancer, but only if the screening for the past 10 years has been negative. This could mean 3 consecutive negative pap smears or 2 consecutive primary HPV tests leading up to age 65. There are several specific populations that have their own high-yield cervical cancer screening recommendations that are worth committing to memory. First are patients who are HIV positive. In this patient population, if the patient is younger than 21, a pap smear is indicated within 1 year of onset of sexual activity. If the patient is 21 or older, on the other hand, a pap smear is indicated at the time of HIV diagnosis. After that initial pap smear, a repeat pap smear should be obtained annually until 3 consecutive negative results are reported. At that point, the patient may be continued on the regular screening schedule. Immunocompromised patients should receive a pap smear within 1 year of onset of sexual activity, and a pap smear with HPV co-testing is indicated annually thereafter for as long as they remain immunocompromised. For patients who have undergone a total hysterectomy, meaning that both their uterus and their cervix were removed, no cervical cancer screening is indicated if the patient has no history of CIN2, CIN3, or carcinoma in situ in the last 20 years. Lastly, for patients with in utero DES exposure, a pap smear is indicated annually for the rest of their life. In what patient populations may cervical cancer screening be indicated at age younger than 21? The only 2 patient populations that may need cervical cancer screenings at age younger than 21 are either patients with HIV or patients who are otherwise immunocompromised. For all other patients, cervical cancer screenings will not begin until age 21. Unfortunately, it isn't enough just to know the indications for a pap smear. It's also important to know the best next step in management given a specific pap smear result. So let's discuss that next. Generally speaking, a pap smear may produce one of the following 7 results: negative or normal, atypical squamous cells of undetermined significance, atypical squamous cells, cannot rule out high-grade lesion, low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, atypical granular cells, and squamous cell carcinoma. Now, the guidelines on management for each of these results change very frequently, and it is impossible to exhaustively cover every little management option for each of these results. What we can do, however, is go over the most commonly tested management steps in the form of 2 simplified algorithms. Suppose a patient presents to the clinic for a routine pap smear at the age of 21 to 24. If the pap smear result is negative, the next best step is to continue the patient on routine screening, which means a repeat pap smear in about 3 years. If the pap smear shows ASC-US, clinicians have 2 equally viable options. They can either obtain a repeat pap smear in 12 months or proceed with HPV co-testing. If HPV co-testing is obtained and results are negative, the patient should be continued on the routine screening schedule. If, on the other hand, the HPV co-testing results are positive, the clinician should obtain a repeat smear in 12 months. If the pap smear result shows LSIL, clinicians should obtain a repeat pap smear in 12 months. And if the pap smear report shows ASCH, HSIL, or AGC, the clinician should proceed straight to colposcopy. Notably, young patients are quite unlikely to have an undiagnosed squamous cell carcinoma, which is why it is left off this algorithm. Again, the goal is to highlight only the most frequently tested scenarios, rather than every possible scenario. Now, suppose a patient presents for a pap smear at age 25 or older. If the pap smear results are negative, proceed with routine screening. If the pap smear results show ASCUS, the next best step is to consider high-risk HPV testing. If it is unavailable, clinicians should repeat a pap smear in 12 months. If it is negative, clinicians should repeat a pap smear with HPV co-testing in 3 years. And if high-risk HPV testing is positive, clinicians should proceed straight to colposcopy. If the pap smear results show LSIL, clinicians should once again consider high-risk HPV testing. If it is positive or unavailable, clinicians should proceed straight to colposcopy. If it is negative, on the other hand, clinicians may either opt for co-testing in 12 months or proceed to colposcopy anyway. The second half of this algorithm is a lot simpler. If the pap smear results show ASCH, HSIL, AGC, or SCC, the next best step is to proceed straight to colposcopy. I'd like to mention once again that the two algorithms we just went over illustrate a very simplified approach to management of different pap smear results. Again, these guidelines change all the time, and it is entirely possible that they may vary slightly from one resource for the boards to another. That being said, if you are comfortable with the two algorithms discussed in this lecture, you should be able to confidently answer the vast majority of related questions on the boards. A pap smear obtained from a 37-year-old female demonstrated atypical glandular cells. In addition to colposcopy with endocervical curettage, which additional diagnostic procedure should the patient undergo? The correct answer is an endometrial biopsy. Examiners expect students to know about several important indications for an endometrial biopsy, one of which is described in this question. Specifically, an endometrial biopsy is indicated for all women aged 35 or older if their pap smear shows atypical glandular cells. This is because atypical glandular cells can be a product of either cervical cancer or endometrial cancer, which is why it is important to assess the patient for both possibilities. A colposcopy with endocervical curettage will assess for cervical cancer, and an endometrial biopsy will assess for endometrial cancer. Now that we've covered the main indications for a colposcopy, let's go over the basic steps of the procedure using this figure. Similar to a pap smear, the procedure begins with placement of a speculum into the vaginal canal to help visualize the cervix. Next, the clinician applies acetic acid to the cervix and inspects it using a colposcope, which is basically a specialized microscope. If the cervix is healthy and has no lesions, it will appear normal under the colposcope. If, on the other hand, the cervix has a lesion, it will become quite apparent with administration of the acetic acid, producing the so-called aceto-white changes. If aceto-white changes are observed, clinicians will proceed with a cervical biopsy and potentially endocervical curettage to sample the cells from the endocervical canal. The biopsy and curettage samples are then sent to a pathologist to establish a definitive diagnosis. What is the primary contraindication to endocervical curettage? Endocervical curettage is often performed during colposcopy to sample the cells from the endocervical canal and minimize the likelihood of missing an insidious malignancy. However, endocervical curettage is contraindicated during pregnancy. This is because disrupting the integrity of the cervix may interfere with the normal course of pregnancy and lead to complications. Now that we've covered the key features of diagnosis of cervical neoplasia, let's discuss management, which always starts with strategies for prevention. Specifically, HPV vaccination, for example, using the vaccine called gardasil, should be offered to all males and females age 9 through 45. Remember, high-risk HPV strains are the primary etiology of cervical cancer, which is why it is so important to be vaccinated against them. In addition to vaccination, it is also important to counsel patients on safe sex practices, such as consistent use of condoms in order to minimize the likelihood of contracting HPV. If, however, the patient already has cervical neoplasia and it is too late for prevention, the management is based largely on the degree of cervical intraepithelial neoplasia, or CIN. CIN1, which roughly corresponds to a finding of LSIL on pap smear, is usually managed with observation and follow-up testing. CIN2, which roughly corresponds to a finding of HSIL on pap smear, is usually managed with observation in young women. In older women, however, clinicians may consider ablation of the transformation zone, for example using cryotherapy or cold knife or laser conization. Lastly, CIN3, which also corresponds to a finding of HSIL on pap smear, can be managed with either ablation of the transformation zone, cold knife or laser conization, or loop electrosurgical excision procedure, also known as LEEP procedure. Among the different types of CIN, the management of CIN3 is the most high yield, as CIN3 is the most likely to progress to carcinoma in situ or cervical cancer. This figure illustrates the process of cold knife conization, which is often performed to treat patients with diagnosed CIN3. In this procedure, a clinician uses a scalpel to cut out a cone-shaped piece of the cervix in order to excise all of the abnormal cells within the cervix and the cervical canal. The idea is to remove all of the abnormal cells, thereby minimizing the risk of progression to cervical cancer. What complications may develop following cervical conization? There are 4 potential complications that examiners want students to know about following cervical conization. Those are second trimester pregnancy loss, preterm birth, premature rupture of membranes, and cervical stenosis. All of these complications occur because cervical conization disrupts the integrity of a healthy cervix, which may interfere with its normal function. This figure illustrates the loop electrosurgical excision procedure, or LEEP for short. Similar to cold knife conization, a piece of cervix is excised during this procedure, except this time a clinician uses an electrosurgical loop instead of using a scalpel. Once again, this is done to remove all abnormal cells and tissue and thereby minimize the likelihood of progression to cervical cancer. When it comes to management of invasive cervical cancer, for example a squamous cell carcinoma, the clinical algorithms and decision trees are quite complex and are mostly beyond the scope of USMLE Step 2. The gist of management is that it is based on clinical staging, which itself is based on the extent of spread of cervical cancer. Once the cervical cancer has been clinically staged, clinicians use a combination of surgery, for example hysterectomy, radiation therapy, and chemotherapy to treat patients. Though the management of invasive cervical cancer isn't super high yield, it is very important to know that the main complications of cervical cancer arise from the fact that it has a tendency to invade and obstruct surrounding structures, for example the bladder or the urinary system. In fact, the most common cause of death in patients with end-stage cervical cancer is post-renal failure due to hydronephrosis. To further illustrate the point on the previous slide, let's take a look at this figure. Cervical cancer that originates around the cervix can spread directly to surrounding structures, such as this left ureter over here, leading to obstruction and subsequent organ damage. Once again, invasion of the urinary system and subsequent post-renal failure due to hydronephrosis is the most common cause of death in patients with end-stage cervical cancer. Let's conclude this lecture with a multiple choice question. A 23-year-old female presents to clinic for a scheduled pap smear. Her past medical history is unremarkable. She takes oral contraceptive pills for birth control. She denies alcohol use. She says she smokes 1 pack of cigarettes daily. She says she's had 4 male sexual partners in the last 6 months. She describes her use of condoms as inconsistent. Blood pressure is 123/77, pulse is 72, and temperature is 37.1 degrees Celsius. A pap smear is obtained, and the preliminary analysis is consistent with atypical glandular cells. Which of the following is the next best step in management? A. Colposcopy with endocervical curettage. B. Colposcopy with endometrial biopsy. C. HPV co-testing. D. Follow-up pap smear in 1 year. Or E. Cold knife conization. The correct answer is A. Colposcopy with endocervical curettage. This is a case of a 23-year-old female who presents to clinic for a scheduled pap smear. The key information from the question stem includes her age, the finding of atypical glandular cells on her pap smear, and of course, the question of what is the next best step in management. Recall from this algorithm that if a patient between the ages of 21 and 24 has atypical glandular cells, or AGC, on her pap smear, the next best step in management is a colposcopy. This is why option A, colposcopy with endocervical curettage, is correct. Option B, colposcopy with endometrial biopsy, is incorrect because this patient does not need an endometrial biopsy. An endometrial biopsy would be indicated if atypical glandular cells were detected in women over age 35. Since the patient in question is only 23 years old, an endometrial biopsy is not indicated at this time. Option C, HPV co-testing, is incorrect because it wouldn't change management. This patient would need colposcopy whether HPV co-testing comes back negative or positive. Option D, a follow-up pap smear in 1 year, is incorrect because this patient needs a colposcopy now to better assess her risk of cervical cancer. Lastly, option E, cold knife conization, is incorrect because this patient first needs a colposcopy with appropriate biopsies to determine the extent of her cervical intraepithelial neoplasia. As such, it is too early to know whether this patient would benefit from cold knife conization or not. This concludes our lecture on cervical neoplasia.